Dictation patient Simon, S-I-M-I-O-N, Janice, J-A-N-I-C-E. Please address to Dr. Field, F-I-E-L-D, initial C, paragraph. Janice is pleasant, 65-year-old female who was seen MAR 21/19 regarding possibility of connective tissue disease. She has a history of arthralgias related to OA with no history of joint swelling or prolonged stiffness, and has history of photosensitive rash as well as dysphagia, which right now improved. Her blood work showed positive ANA 1/320 with negative ENA and anti-double-stranded DNA when checked in the past. Also, her PFTs were normal, and she had abnormal esophageal manometry. And paragraph. She has been experiencing minor discoloration of the right index finger and has no joint swelling. She has been on Plaquenil. She has been on Plaquenil 200 milligrams BID since 2016. She has possibly a Raynaud's paragraph. She has not developed any new symptoms since I seen her last. She reports 17 pounds weight loss. Paragraph. Current medications: Plaquenil 200 mg BID and Tylenol sporadically. Paragraph. Allergies: Sulfa. Paragraph. FHX. Father OA. Brother spondylitis and ALS. She remains non-smoker. Paragraph. P/E showed no rashes, no periangal erythema, digital pulp atrophy or ulcerations, and no evidence of either tender or swollen joints. Paragraph. Impression. Undifferentiated connective tissue disease, and also evidence of osteoarthritis. Overall, good response to Plaquenil. Janice will continue current treatment. I ask her to reduce the dose to 200, alternating with 400 milligrams every other day. She was also reminded about eye exams and wearing sunscreen throughout the year, more than SPF 50. Paragraph. F/UP MAR/20. Patient Bragg. BRAGG, Karen, KAREN. Please address it to Dr. Duncombe, DUNCOMBE. Initial J, paragraph. Thank you for re-referring Karen. Thank you for referring Karen, who is known to me, 56-year-old female whom I seen 2 years ago. With respect to osteoarthritis, she was thoroughly investigated for inflammatory arthritis, and her blood work and her investigations were unremarkable. At the present time, she is experiencing pain over CMC joints and occasionally over several DIP joints of both hands. Stop. She has been using Celebrex cream once a day, but she has never tried colchicine that I recommended in the past. She also has Dupuytren's contracture, left more than right, and she will have surgery by Dr. Short in the near future. Stop. The biggest issue she has is with the pinching paragraph. Current medications, Celebrex cream, multivitamins, and Xarelto. Paragraph, allergies, codeine, paragraph, past medical history, pericarditis at the age of 5, bacterial meningitis 2011, multinodular goiter, pulmonary embolism twice, protein C deficiency, endometriosis and multiple miscarriages, paragraph. Physical exam revealed OA changes with joint line tenderness, stress pain, and no swelling at the CMC joint. Also, OA at the DIP joint, with left second DIP being tender with no evidence of synovitis. Paragraph, impression. Karen has osteoarthritis. The most affected joints are her CMC joints, and I recommended she wears thumb splints at night, and she may also consider using small splint for the right second DIP. She will also try colchicine 0.6 mg BID. Benefits and side effects were explained. She will also use Celebrex cream. In case any of the joints are exceptionally painful, I can inject them with cortisone. Stop patient Daggubati, Daggubati, Radhika, Radhika. Please address it to Dr. Kadawandi, Khodawandi, initial K, paragraph, date of visit, MAR21/19, paragraph, DGX, RA, RF, and anti-CCP positive, paragraph, Mets, Aleve, vitamin B12, paragraph, allergies, none, paragraph, interim history. Radhika had x-rays done of hands and wrists, which showed evidence of osteopenia with no erosions. Ultrasound showed synovitis in multiple joints corresponding to findings on physical examination, including MCP and PIP joints of both hands, as well as MTPs. Her symptoms started to escalate, and she is in a little bit more pain and more stiff in the hands as well as in the left shoulder. P/E showed evidence of 8 swollen joints and 4 tender, no damage. Physician global 2, paragraph, blood work, normal CBC, ESR2, CRP 3.4, ALT 1.5, creatinine 59, creatinine 59, negative hepatitis B and C serology. Paragraph, impression. Radhika has seropositive rheumatoid arthritis. I discussed with her therapy and suggested that she starts as soon as possible methotrexate in combination with Plaquenil. Benefits and side effects of both medications were explained. She will take MTX 20 mg POOW plus folate 10 mg POOW and Plaquenil 200 milligrams BID. She was given requisition to do blood work monthly and informational pamphlets about both medications. Stop. In case of intolerance, she was asked to contact my office. Otherwise, I will see her at 3 months time or sooner if necessary. Stop. Dainard, D-A-I-N-A-R-D, Carol, C-A-R-O-L-E. Please address it to Dr. Hooper, H-O-O-P-E-R, initial C, paragraph. Catherine was reviewed, MAR 21/19, regarding possibility of PMR. Stop. She is known to have history of CAD, idiopathic edema, migraine headaches, OSA, GERD, asthma, COPD, and hypothyroidism. Paragraph. She remains on vitamin D, 1000 IU per day, Lasix, progesterone, Pariet, Zopiclone, estradiol patch, Avamis, citalopram, Crestor, levothyroxine, Align, Advair, and Vitalux. And please put all those medications bolded. Paragraph. Allergies, codeine. Paragraph. Since I've seen her last, she has been experiencing achiness in both shoulders and some burning sensation in both hands. She had exacerbation of COPD and has been treated with course of prednisone, and after this was discontinued, some of her fatigue persisted, as well as stiffness returned, particularly in the shoulders. Blood work that I've done showed negative RF, anti-CCP, and HLA-B27 serology, creatinine 102. Ultrasound of both hips showed a mild bilateral OA, gluteus tendinosis, and mild bilateral trochanteric bursitis. Paragraph. Today on physical examination, she has tenderness in both shoulders, more so right one, and no evidence of tender or swollen joints otherwise. Paragraph. Impression. I discussed with Carol possibility of PMR and decided that she needs to right now complete follow-up blood work. Stop. Her previous abnormalities could have been related to exacerbation of COPD. She has been dealing with. Stop. I will contact her after the blood work is completed. Stop. Peralta, P-E-R-A-L-T-A, Agnes, A-G-N-E-S. Please address it to Dr. Georges. To Dr. Espiari, E-S-P-I-A-R-I, initial A, paragraph. Thank you for referring Agnes, who is 50-year-old female known to me, regarding follow-up of her small vessel vasculitis. Stop. She has been originally seen in December of 2014. She has a history of vasculitic rash, leukopenia, and abnormal serology for anti-double-stranded DNA, SSA, and SSB. She has been treated initially with prednisone in combination of Plaquenil and for a period of time with Imuran, and improved. She is also known to have bilateral carpal tunnel syndrome, but has no evidence of small fiber neuropathy, had no evidence of small fiber neuropathy on nerve conduction studies. She still is experiencing recurrent paresthesias in her hands, but otherwise there has been no change in her symptomatology. She has no rashes, mouth or nasal ulcers, hair loss, and her respiratory, cardiac, and abdominal inquiry is negative. She also has no symptoms suggestive of Raynaud's or Sjogren's. Paragraph. Medications, Plaquenil, 200 mg BID. Paragraph. Paragraph allergies. Allergies, none. Paragraph P/E revealed no rashes. Thyroid enlargement or lymphadenopathy, normal heart sounds, lungs clear to auscultation. MSK exam revealed osteoarthritic changes in the hands with no tender or swollen joints. Paragraph blood work done recently showed WBC 3.4 with lymphocytes 0.9, normal hemoglobin and platelets, ESR 6, creatinine 57, ALT 13, normal TSH, B12, anti-dsDNA 22, positive ANA 1/320, CRP 0.3, and negative rheumatoid factor. Paragraph impression. Agnes has small history of small vessel vasculitis and related to a possible systemic lupus or undifferentiated connective tissue disease. She will continue Plaquenil, but I reduced her dose to 400, alternating with 200 mg per day. She was also referred for follow-up nerve conduction studies, and I will call her with results. Otherwise, I'll see her in review in fall of this year. HEAL Meredith, MEREDITH, initial L. Please address the Dr. Khalid, KHALID, initial S. Paragraph. Thank you for referring. Thank you for referring. Meredith, who is 38-year-old female. With respect to bilateral knee pain, she has a history of of juvenile inflammatory arthritis, diagnosed at the age of 8. She was under the care of sick kids and treated with anti-inflammatory medications. Inflammatory arthritis in her situation was polyarticular. She does not recall being treated with any of the disease-modifying anti-rheumatic drugs. Paragraph. She has been well for many years, but about 2 months ago started to experience increasing pain in her both knees. She has mostly difficulty walking up and down stairs and less so on a flat ground. She is not experiencing any swelling or significant stiffness. She has no history of psoriasis, IBD, or uveitis, and there is no history of inflammatory back pain. Paragraph. Current medications: Wellbutrin 300 mg OD, clonazepam 0.5 mg PRN, PRN. Paragraph allergies, none. Paragraph FHX, mother, OA, gout, breast CA, father, skin CA. Paragraph. She is non-smoker. Paragraph P/E reveals a person with elevated BMI, normal vitals, no thyroid enlargement or lymphadenopathy, normal heart sounds, lungs clear to auscultation. MSK exam revealed patellofemoral crepitus bilaterally, bone on bone, and no evidence of medial or lateral joint line tenderness, effusions, or stress test. She had normal alignment, and mobility in the hips was also normal. There was no evidence of synovitis. Paragraph X-rays of both knees revealed uniform joint space loss in medial and lateral compartment, but most of all she had decreased joint space and minor osteophytes at the superior aspect of both patella. No erosions. Paragraph. impression. Meredith has a history of juvenile inflammatory arthritis as a child, and right now has recurrence of bilateral knee pain. Bilateral knee pain stop. She's symptomatic mostly due to patellofemoral OA stop. She was advised to use patellar brace and start quadriceps strengthening exercises. Stop. To control her pain, she may use Advil or Aleve as needed. Lastly, she was referred for relevant blood work as well as MRI of both knees to make sure she has no synovitis. Stop. I will review Meredith after MRI is completed. Stop. Thank you for referring this patient for consultation. Stop. Pringle, Kevin, Kevin, initial D. Please address Dr. Williams, Williams, initial C. Paragraph. Thank you for referring Kevin, who is 51-year-old female, with respect to inflammatory arthritis. Paragraph. Kevin has been experiencing pain in his hands, mostly over DIP joints, on a daily basis. Some of the PIP joints are achy as well. He has not observed any swelling. He works with his hands as a tool maker, works on various machines, uses wrenches and other tools, and including vibrating tools. He's not experiencing any color changes in his digits and has no symptoms of numbness or paresthesia. Stop. He has no symptoms suggestive of dactylitis. There is no history of psoriasis, IBD, or uveitis. Stop. He has been recently diagnosed with type 2 DM and is known to have GERD. Paragraph. Current medications: metformin, Celebrex, daily unknown dose, and Nexium. Paragraph. Allergies: none. Paragraph. Allergies: none. No history of PUD or GI bleed. Paragraph. FHX: mother, breast CA and DM, father ALS, Alzheimer's. Paragraph. P/E, BP 127/70, no pedal edema, no rashes, nail lesions, normal heart sounds, lungs clear to auscultation. MSK exam revealed OA changes over PIP and more so DIP joints of both hands. Some of the DIPs only were slightly tender. There was no synovitis. Paragraph. X-ray describes degenerative changes, mostly at the DIP joints, with possible erosions. But X-rays were not available to review. Paragraph. Blood work: negative RF and ANA, CRP 1.1. Paragraph. Impression: Kevin has aggressive osteoarthritis, but there is no clear evidence of inflammatory arthritis. I suggested that he continues Celebrex for a while, and if once the pain diminishes, he may want to lower his dose and eventually stop it and only take it as needed. I also prescribed diclofenac 10% cream 3 times a day. We talked about glucosamine sulfate, compression gloves, and splints as needed. Lastly, he was referred to Arthritis Society of Canada for further advice from hand therapy and education. Stop. Thank you for referring this patient for consultation. Stop. Patient Sweet, SWEET. Joanna, Joanna. Please address it to Dr. Gill, Gill, initial S, paragraph. Thank you very much for referring Joanna, who is 33-year-old female, with respect to possible early RA. Stop. She has mother who has confirmed RA for a decade, paragraph. Joanna has been more achy within the last 2 years, but more so than ever. She has some pain in certain MCP joints of her hands and also in her feet. Ankles, and knees. She hasn't noticed any obvious joint swelling, but she is simply stiffer. She has no history of psoriasis, IBD, or uveitis, and there are no symptoms suggestive of Raynaud's or Sjogren's. Her energy level is quite good. Paragraph. Current medications, none. Paragraph. Allergies, none. Paragraph. She's lifelong non-smoker. Paragraph. She has 2 children, ages 4 years and 9 months, and is not planning further pregnancies. Paragraph. P/E BP 120/70, no pedal edema, no rashes and no nail lesions, no rheumatoid nodules. MSK, a normal general physical exam, MSK exam revealed joint line tenderness, stress pain over right first and third MCP joint with minor swelling at the right third MCP. Paragraph. Blood work RF14. Paragraph. Impression. Joanna has increasing arthralgias and possible synovitis over right third MCP joint. She also has strong family history of RA. We have to consider possibility of early RA, and she will do additional blood work as well as PDUS of hands and wrists. I will contact her as soon as the results are available to discuss the results, diagnosis, and treatment. Stop. Thank you for referring this patient for consultation. Stone, EASTON, Jody, JODI. Please address the Dr. Surge, SEURADGE, initial J, paragraph. Thank you very much for referring Jody, who is a 45-year-old female with respect to possible connective tissue disease in view of her positive ANA serology 1/80 speckled pattern. Paragraph. Jody has been experiencing some achiness in the right thumb as well as both elbows for the last 6 or 8 months with no evidence of joint swelling. She has no history of fatigue, fever, chills, or weight loss. She also has no history of rashes, photosensitivity, mouth ulcers, alopecia. Her respiratory, cardiac, and abdominal inquiry is negative. She has also no symptoms suggestive of Raynaud's or Sjogren's. There is no history of thromboembolic complications, seizures, or psychosis. She suffers from anxiety / depression, which is treated. Paragraph. She is non-smoker. Paragraph. Meds, citalopram 20 mg/OD. Paragraph. Allergies, none. Paragraph. FHX adopted. Paragraph. P/E BP 122/70, no pedal edema, no rashes, no alopecia, normal heart sounds, lungs cleared, auscultation. MSK exam reveals absolutely no evidence of tender or swollen joints. She had tenderness to palpation, mild tenderness to palpation over both lateral epicondyles, and that was reproduced with stress maneuvers. Stop. Paragraph. Blood work, ESR2, CRP 1.1, RF negative, HLA B27 negative, ALT 14, normal CBS, creatinine 67. Paragraph. impression. Jody has no evidence of connective tissue disease based on her overall presentation, available blood work and physical examination findings. I don't think she requires any additional investigations at the present time. She does have mild bilateral lateral epicondylitis, and we discussed treatment options for it. Stop. She agreed with this plan. Stop. Thank you for referring this patient for consultation. Stop. Patient Bastos, B-A-S-T-O-S, Irene, I-R-E-N-E. Please address it to Dr. Dr. Moore, M-O-O-R-E, initial B and M, paragraph. Thank you for referring Irene, who is 55-year-old female, with respect to a possible RA. Stop and paragraph. Irene has been experiencing pain and swelling over a couple of PIP joints since January. Right now, she also has pain and stiffness in both ankles and both knees. She is stiff all day, and the pain at times can be very severe, 7 to 8 out of 10. She is doing typing for a living, and this aggravates her pain. Paragraph. No history of psoriasis, IBD, or uveitis. No history of rashes, hair loss. Stop. She has no symptoms suggestive of Raynaud's or Sjogren's. Paragraph. Meds, none. Paragraph. Allergies, none. Paragraph. FHX, uncontributory. Paragraph. P/E, normal vitals. Stop. Normal heart sounds. Lungs cleared. Auscultation. MSK exam reveals synovitis over right third. PIP. Left second and third PIP and left second and third MCP joints, and stress pain across MCPs bilaterally. No enthesitis or dactylitis. Paragraph. Blood work. CRP 3.8, RF 72, normal CBC, creatinine 78, ANA negative, urate normal. Paragraph. Impression. Irene has evidence of inflammatory arthritis, which likely represents early RA. I discussed with her diagnosis and suggested she starts methotrexate in combination with Plaquenil right away. Benefits and possible side effects of both medications were explained. She will take 20 mg of Plaquenil along with folate, 20 mg OW, and also starts Plaquenil 200 mg BID. Stop. She was referred for additional blood work, including anti-CCP testing, as well as chest X-ray. She also received IM Kenalog, 80 milligrams right now, to treat her as soon as possible. Paragraph. F/UP 3/12. Stop. Anna Jaroszyńska. This is a dictation on patient Badwal, B-A-D-W-A-L, Surinder, S-U-R-I-N-D-E-R. Please address Dr. Tiriani, T-H-I-R-Y-A-Y, initial W. Thank you very much for referring Surinder, who is pleasant. Who is pleasant, 69-year-old female with respect to possible systemic lupus. She was seen MAR 21/19, paragraph. Surinder is poor historian. She explains to me that she has a rash over her left breast and possibly had it across her chest, but it has now improved. The rash has been erythematous and rather transient on her face. She also has History, she has no history of hair loss or alopecia, no thyroid enlargement or lymphadenopathy. She has normal heart sounds, lungs clear to auscultation. MSK reveals no synovitis. Paragraph, blood work, and positive anti-dsDNA. 1/640 speckled pattern, ferritin 8, TSH 4.51, abnormal platelets with elevated elevated alpha-2 globulin, beta-1 and beta-2, and normal IgG. Paragraph, impression. Actually, sorry, before we say that paragraph, physical exam, if I said this the beginning, a physical exam reveals reveals person with elevated BMI, blood pressure 122/70, no pedal edema, normal heart sounds, lungs clear to auscultation. MSK exam reveals OA at the CMC joints with no synovitis. There were skin changes, so overlying left breast with hyper and hypopigmented area, as well as over left lower quadrant. Paragraph, blood work, elevated IgE at 331. Negative anti-dsDNA, positive ANA 1/640, abnormal serum electrophoresis and plaquenil. Paragraph, impression. Surinder has mild OA and abnormal blood work, but there is she does not have clear evidence of connective tissue disease. Connective tissue disease. If her rash reappears, you may consider referring her to one of the dermatologists or plastic surgeons for biopsy. I will contact Surinder after receiving blood work, especially if it comes abnormal and requires follow-up. Stop. Anna Jaroszyńska.